Lovely. Hello, good afternoon. We'd like to take the opportunity this afternoon to introduce you to the Individual Management Plan Outcome Score. It's basically an outcome measure that's been developed at Betsy Cadwallader by the frontline audiologists that work there. If you're going to try something on Monday, try this. If you're using IMPs, try this. So why did we feel the need to develop a new outcome measure? So historically we were doing GHAB, but our completion rates weren't great. Clinicians didn't see the added value of the GHAB, and if they were running tight on time on a follow-up, they just saw the GHAB as expendable. So we sort of looked at the common principles that were around at the time, and those have just been updated recently, and we actually wanted something more patient-centred, and that actually sort of assessed patients' needs around more than just the hearing aid fitting, around sort of all the additional things that we can do to help our patients that encompasses the whole of adult oral rehabilitation. The majority of the existing tools were standardised, so that put them to one side. Of the individualised ones, we wanted something that was efficient, so we didn't want anything with a derived benefit, like a gas, where you're doing a before and after measure, or you've got a complex calculation involved. We wanted this to be as sort of user-friendly as possible. GHAB and COSI, obviously, they have patient volunteered needs, but they both focus on hearing aids, and that's not what we wanted. We had a suspicion that the IMP, as outlined in the adult rehab quality standards, might hold the key to this, and we're big champions of this in North Wales. We love our IMPs, and we wanted to develop that further. So the way that we developed it followed this development cycle. I'm going to go through each of these boxes in a little bit more detail, but the final stage, this stage 3, isn't a finite stage. It's about a sort of a growing library of clinical validation studies that backs up your outcome measure as time goes on. So our stage 1 was, we wanted to come up with a really definite criteria of what we wanted our outcome measure to achieve for us. We had a look at the literature to see if there was something out there that did the job. We didn't find it. So then we decided to develop our own measure. We then went on to stage 2. We discussed this new measure with our staff, and we took their opinions into account, and then we piloted it. We decided to just take a convenient sample. We just said, right, we'll start trying it. We'll just see what the feedback is from clinicians and see what the problems might be. So they were new and existing patients. They went through their routine intervention, and at the end, they did an IMPOS at their final follow-up face-to-face. The first bit of the stage 3 was we actually thought, well, let's compare IMPOS to a currently used validated outcome measure. And we chose the GHAB because that's what we were familiar with. So this time we limited it to new patients only. They went through their routine intervention, and then at the end of the follow-up, they did a face-to-face GHAB, and about 4 months later, they actually did a postal version of the IMPOS. So let's have a look at the service-driven criteria that we wanted. So like I said before, we wanted something that was efficient, that was easily integrated into clinical practice. We didn't want more of the same where clinicians saw it as expendable and they just didn't see the value of it. And again, like I said, we wanted something that was directly measured. You measured it once and that was it. We wanted it available in different formats so that we could do it over the phone or via postal methods. If you've ever seen the postal version of a GHAB, that's not very user-friendly, so we wanted to overcome that. But we also wanted it, like I said, appropriate for non-instrumental intervention. We wanted to reflect those individuals' outcomes, whether those be hearing outcomes, hearing needs, psychosocial needs, tinnitus needs, anything at all. But we wanted it to do that robustly. We wanted to encourage and facilitate those IMP developments, but we also wanted the data to tell us something about our service. So we wanted it to help sort of drive patient care and that individual relationship, but when we looked at the overall, we wanted to learn something about what we were doing. So like I say, we didn't find anything, and then we went on to develop the IMPOS. So what is the IMPOS? Let's have a look. So if you're doing IMPs in your daily clinical practice, a lot of this is going to seem really familiar. You've got your needs at the top here that you agree with your patient. They're volunteering those, and you're agreeing the wording on those. They can be anything from I need to hear the television to reducing the distress caused by my tinnitus. You plan your actions, you go through your plan and you complete your actions, and then at the end of your plan, you write your outcome comments. You have that chat with your patient and you say, well, let's remember why we did this, what we did at the beginning, and how are we achieving those needs. What we've done with the IMPOS is we're adding a little numerical score at the end here based on this line at the bottom. So we've gone for a scale of 0 to 100. In those 5 increments, in those 5 sort of unit increments, that gives us a scale of 21 points. With the COSI, some of the validation data on the COSI gave us a hint that some of these outcome scores might bunch up in the top half because, generally patients are quite happy with what we do, but, if it bunches up at the top end, it still left us with 11 points available. What you can also do is not only calculate have the patient volunteer individual scores for each need, but you can calculate a global score for that plan as well. So overall, that pathway gets a global score as well. And then from here, this is the patient format for the same plan. So you've got each individual need, you've got the scale on each one, you post it out and they mark across as to how well they feel that need has been achieved. It's not about how satisfied are you with your hearing aid. So when we ran the pilot, we tried it out and we had really positive results. Our patient participation rate was 92%, and that means that 92% of those 64 pathways had either a completed IMPOS or even a partially completed where some of the needs weren't quite completed. We looked at that, we said, well, why aren't these needs being completed? Why haven't they been scored? We sort of did a rough categorization where we looked at the type of need it was and also the reason why that need hadn't been scored. So the biggest category was listening needs, but that was quite a varied category. But the most sort of prevalent, sort of unique need was telephone conversation. Patients just weren't happy kind of volunteering how they were getting on the phone because they weren't happy with how they were getting on the phone. And then when we look at the reasons for unscored need, again, sort of telephone conversation, but actually some real life situations come up as well. They haven't bought a new telephone yet, or they haven't had the opportunity to try the loop at the theatre. Sometimes these things come up. So we reviewed these reasons with our clinicians and we said, right, well, what do you think would work better? And we developed the protocols in line with how we all felt that we could implement this better. And that's the version that went on to stage 3. So the stage 3 was where we compared the GHAB face-to-face with the postal IMPOS. So the return rate for the postal IMPOS, again, was really favourable. We had a patient participation rate of 85% there. As suspected, they all bunched up in the 40 to 50 range at the upper end of the scale. And that sort of made us think, well, okay, we're on the right track here. We're right to sort of have lots of increments because it gives us increased sensitivity. Patients can, particularly, patients that are really happy with their outcomes can come a little bit higher, and those that are not happy can actually go a little bit lower, and it gives us something to work with to identify maybe those patients that haven't been as successful. We sort of looked at potentially confounding sort of aspects of the IMPOS, and there was a bit of variability between the delay of the GHAB and the administration of the postal, and there was an inverse correlation there. So the longer we waited, the less likely they were to be happy with their outcomes and compared to the GHAB. But actually, for us, that was a case of, well, if there's going to be a correlation, we're less likely to find it. So, it wasn't too important for us at that point. Also, we found an age effect. So bearing in mind that these are first-time fitting patients or hearing assessment patients, we again found an inverse correlation. So the older a patient was when they went through their pathway, the lower their outcomes were. Gender and ear, their hearing didn't actually have an effect on the IMPOS. So when we looked at the correlations, bearing in mind that we were a bit concerned that because there was this variability and delay, we might not find a correlation between GHAB and IMPOS, we did find a really nice, strong correlation between the two, particularly when we compare the global IMPOS with global score, residual disability and satisfaction. So that made us really confident that we were on the right track. You know, IMPOS can reliably reflect patients' outcomes, but can it do it robustly? That was sort of the next question that we had, and that's where I pass on to Paul.
Thank you. Thank you. So the next stage of the development of IMPOS was looking at its test-retest reliability, and this was actually my MSc dissertation, which was sponsored by the University of Manchester. So our participants were 15 new hearing aid patients, and they were quite representative of a typical sort of adult caseload. So we're looking at mainly mild to moderate sensory neural losses. We applied various exclusion criteria here just to ensure that the sort of underlying effectiveness of the hearing aid was as stable as possible across the study. So we excluded things like fluctuating hearing losses and patients where their hearing aids were adjusted at follow-up. So the diagram at the bottom here shows the protocol for the study. So we recruited patients at their follow-up, which is typically sort of 8 to 12 weeks after they're fitted with a hearing aid. IMPOS was completed face-to-face at that point. Then roughly 2 weeks later, they were sent a postal copy of IMPOS. And then once they'd returned that via post, a further copy was sent to them by post, again, roughly 2 weeks later. The idea of having the two separate postal questionnaires was so that of the 3 administrations of IMPOS, 2 of them were under the same conditions. So now looking at the results of the study, it should be pointed out here that we're looking at global scores averaged across each patient's needs. So the main finding was that we've got a significant and strong correlation between face-to-face follow-up in clinic and the first postal questionnaire. And this value of 0.71, that's at a level that's appropriate for the measure to be used in service evaluation and research. Interestingly, we found a stronger correlation between the two postal questionnaires here, 0.87, and that's of a sort of level that indicates that the measure could be used to guide individual rehabilitation. We also, as a secondary aim, looked at the critical differences of the scale. The critical difference is essentially the minimum amount that a score needs to change by on repeated administrations for that to be statistically significant. And a lower critical difference value represents greater sensitivity of the scale. And what we found there was that these critical differences were also lower for postal administration than they were for face-to-face. And interestingly, as shown in the final graph here, there was no systematic change in the magnitude of scores across the 3 administrations. So now looking at how IMPOS can be used in practice. Firstly, it can be used as a service evaluation tool. You could potentially look at your global scores at different sites to compare different services. You could also do, if you want to look at make comparisons between different patients, it can be quite tricky because the needs that are being agreed with patients at their first appointment are very individualised, very specific to that patient, which can make comparisons between patients difficult. So what work is underway to come up with separate categories of listening need that patients' own needs can be classified into. So you could then come up with a distribution of scores for different types of listening need across patients. So things like the television, alerting, which would be like smoke alarms, doorbells, things like that, telephone conversation. And some preliminary work, as is shown here, has been done already. And what this shows us is that your scores tended to be higher for the need relating to listening to the television, which is that line there. As you might expect, that tends to be an easier listening situation than something like the telephone, where the pink line, where the score is, tend to be typically worse. And the application of this in practice is you can look at two things. Firstly, is an individual patient's score too low? Do we need to revisit their IMP, look potentially at other interactions? And secondly, at a service level, if a lot of your patients are all tend to be scoring poorly for one type of listening need, for example, alerting, you could ask yourself whether, as a service, you're doing enough to address the needs of those patients. So just quickly in summary, we feel as a team that IMPOS fulfills those various criteria we discussed at the start for an outcome measure. So it's efficient, clinicians can use it readily as part of their normal clinical practice. The availability in different formats as well has been demonstrated, so face-to-face in clinic, postal administration, telephone, and also in future potentially online. It's not just for hearing aids, it can be quite easily be applied to interventions other than those using hearing aids. We've demonstrated the reliability of it as a measure, both in terms of the correlation with the GHAB and its good retest reliability. It can be used in practice to assess how well an individual patient's rehabilitation has gone, and also at a service development level it can be used. So finally, further work which is actually ongoing within the department as we speak is the optimisation of the categories of listening need. Someone else is picking up the baton with this and going to be developing different categories of listening need in an evidence-based manner rather than just picking them out of thin air. We're going to also try and develop a version of IMPOS that's appropriate for adults with complex needs. And finally, at the moment, IMPOS exists just within audit base, within their journal. The needs are listed within there, which makes it easy to access during appointments. But then when it comes to gathering data for studies like this, it can be very time consuming to gather this information. So we want to develop potentially a separate IT platform for IMPOS to allow this data to be collected more readily, and also the potential for this to be an online tool that could be emailed to patients or that they could remotely access. Thank you.